While we're setting up, I'm going to introduce our next speaker, Dr. Duan Nguyen. He's going to be talking about the pediatric ACL. Dr. Nguyen is a very accomplished pediatric orthopedic surgeon, works in the William Osler system. But I thought the best way to introduce Dr. Nguyen was that through a conversation I recently had with one of our operating room nurses who's very experienced, has worked in several countries with over hundreds of surgeons, who described Dr. Nguyen as the most technically sound and most skillful surgeon he's ever worked with. Now, I should say that was in context of talking about my superb surgical assist skills. Next up, we have Dr. Nguyen.
Okay, thank you, Neil. It's a Persian name, so I'll make it shorter than normal, and then so we can all have lunch. I'm getting very hot here next to the radiator, so I'm wearing, is John still in the room? John Wong, you just went out. I was just worried about the temperature triggering my Brugada syndrome, and it's just collapsed right here in front of you guys, but hopefully I'll be okay. Here are my disclosures. Nothing pertains to the talk. Follow me on Instagram. I post a lot of techniques about advances in ACLs versus meniscus injuries. Today we're going to talk about pediatric ACLs, how it's different from adult ACL, and how you approach the next patient in your clinic. So this is the case of the week. 12-year-old girl, soccer striker, OPDL level. She had an injury 4 weeks ago. Now she has full motion, no effusion. Dad is a lawyer, mom's a lawyer. They'll look at you very intensely in terms of what's going to happen to my 12-year-old girl. She saw other doctors already. There's a variability in terms of the recommendations. The easiest one to make is just wait till 18. I have to think about the growth plate. But by that time, there's an increased risk for meniscus injury and cartilage damage, which can lead to arthritis in the long term. So that's going to be part of the discussion with the patient and the parents. You just can drill through the soft tissue graft and hope for the best, and nothing is going to close or grow abnormally, but that's risky at 12 years old. As you get older, 13, 14, then the risk decreases. And then the third recommendation is not up until she's 16 and almost closed in terms of the growth plate. And you can do an adult type quadricep hamstring soft tissue graft and not put any metal or any bony blocks across the growth plate. Or you can do surgery now and use the IT band, non-anatomic, loop around the growth plate, as you will see in a few minutes. So the physical exam is very focused. If you do an effusion, any test you want to use, if it's positive, I think, the onus is on you to investigate for meniscus injury or ligament injury or cartilage injury. Confirm full range motion in general for any injuries within 3 weeks. You should try to aim for full motion. Anything short of full extension, you should investigate for locked meniscus or buccal tear. You don't want to miss that for the next 3 weeks. And for sure, a full motion at 6 weeks with minimal effusion. And then you re-examine the knee at 3 weeks and 6 weeks. There's no effusion, there's no drawback tenderness, or your meniscus and ACL tests are normal, then patient can go back to play. Rule out every other injuries with any of those PLC, PCL, and PFL, distal MCL injury associated with an ACL injury. Then you should strongly consider surgery because the knee is very unstable. So imaging is very important in kids. If you're not sure what you're looking at, or the contralateral knee x-rays to compare, to look for things that actually look different. It's like finding Waldo in the room or a picture. You don't want to miss a fracture in a pediatric patient because it will lead to worse outcomes in terms of even though surgery or reconstruction will never be the same as a repair. This is Neil's favorite sign. A softer sign from a pivot injury. If you see this, then highly suspicious from ACL injury. Sigmoid fracture is very common. Look for it as well. In the day and age of ACL ligament reconstruction, this is very relevant because it is associated with ACL injury. X-rays in a kid, you want to make sure you rule out every other fractures. Tendons and ligaments are stronger than the bone, and it will rip off and involve some bone. So if any suspicion on physical exam or history, then do an X-ray. And then this shows a tibial tuberosity fracture, common in the 13 to 15-year-old male boys playing basketball with the eccentric pull, either from a layup or landing. Rule out tibial spine fractures. So again, ligaments stronger than the bone. It involves the tibial spine off the tibia, and then if it's displaced, even in full extension after you reduce on the field, then you should strongly consider surgery. Pediatric knee, so look for weird stuff that looks like a fracture. If it's not tender there, that's usually a good sign it's not broken. If you're not sure, then do a contralateral X-ray. This is a slide from Leah from Arizona when she came to talk about pediatric injuries. And obviously don't miss the patellar fracture. If the patella looks high, then do a contralateral X-ray to make sure it's not avulsed off the tibia or tibial tuberosity or patella sleeve fracture. If you're not sure, do contralateral X-ray. On physical exam, the extensor lag is very important. If they can't do a straight leg raise, something's going on, either an injury, structural damage, or the patient has pain, swelling, and then can't perform it. So repeat it in a week when the patient's more comfortable. And if it's an extensor mechanism rupture or patella sleeve fracture, it mandates immediate surgery. MRI is the best diagnosis for meniscus and cartilage. The ACL, you can pretty much pick that up on physical exam at the 3 weeks mark when the pain inflammation has subsided, and you can perform a better exam with minimal guarding. This is also the slides. So X-rays are very important. We deal with pediatric patients. There's delay, closure of growth plates. There's complications from growth plate injuries, even though they didn't have surgeries. So always do an X-ray if the patient complains of pain. And again, if you're not sure, look at the contralateral X-rays to compare. So growth plate is important for this talk and for the pediatric population. Every time you work around the growth plate, if you have to work around the growth plate, you can either stop working, partially stop working, leading to an angular deformity, or it overgrows. So a lot of blood supply inflammation around the growth plate, it will go on hyperwire growth and then cause an angular deformity from overgrowth. And then femoral physis, distal femoral physis is most important. You don't want to mess with it because it affects the height the most. It provides probably 2/3 of the entire leg. So if you have a 12-year-old and you damage the growth plate, it leads to a lot of complications. So ACL injuries are just for girls. So yes, so between 12 and 16, female athletes are more commonly injured and then more commonly have ACL injuries. But there was a talk today about sports specialization. It's an epidemic in terms of young boys playing the same sport all year long at a high level every day for the whole week. So you're gonna end up with a lot of injuries, and a lot of them is ACL injuries. So less than 12 boys are more commonly injured with the ACL. Decision making is always controversial, and there's a lot of debates every year, every meeting. There's discussions because we really don't have a good solution. We just have semi-good options until they stop growing. And always you have to think revision ACL surgery is not as good as just the first time ACL surgery. So if you expect a 12-year-old to just sit and do homework all day and not run around recess or participate in gym or run around with their friends and goof off at the mall, then you're delusional. So you have to be aware of what's happening. There's a few papers that state that if for some reason you expect a kid to be low key active and comply with the restrictions, then maybe you can buy some time until they stop growing and do the ACL surgery. But then you have to question why you're doing the surgery if they're not active. And if you miss the ACL injury and you allow the kid to play, I can guarantee you in 3 to 4 years to come back with a meniscal tear. And that's been shown in multiple studies. So PEDS ACL consideration for the growth plate. If you do research in this area, then you would do a bone age. Most people don't. Excuse me. Most people just use the rule of thumb that I'll show in a second, but you can rely on atlases and then x-rays that determine which age your patient's at. So surgical options and combinations, it's all about avoiding the growth plate depending on the age of the patient. So you have to consider the ACL, but also the AIL that we talked about, and then consider in a young patient with avulsion, and just do ACL repair versus fully reconstructing the ACL. You can look on the MRI which bundle is torn and do a selective ACL bundle reconstruction. And then the logic and the thinking is that the less you do, the better for this patient and potentially the less complications. Internal brace augmentation is the new thing this year in terms of providing a static stabilizer until the ACL heals and hopefully not overtime the knee as the patient rehabs and returns to play. And then if you look at the literature for pediatric ACL, there's like 1,000 different options you can choose from the transphysial technique where you don't really care about the growth plate, you're just going to drill through it. The smaller the footprint, the better. And then if you add a soft tissue, then cross fingers, there's no complications. And there's a few studies that actually shown some successes, but as you go younger and younger, then the risk increase. So a 12-year-old, if you drill through the growth plate, then something's going to happen to that knee. And it's actually going to fall into the 25, or most likely they end up with some kind of either overgrowth or angular deformity or growth arrest or partial growth arrest. And you have to follow this patient every year until they stop growing and do selective growth plate closure, stapling, and allow one side to kind of equalize the growth compared to the other side. The all-epiphyseal second technique is my preferred technique. It's very technically challenging because you try to drill 2 holes in a very small epiphysis, and a 12-year-old, I can guarantee you, the growth plate is right next to the cartilage. So you have to find the sweet spot on the x-ray and intraoperatively, and then try to squeeze a decent graft, but not too big, through the epiphyses on both the femoral side as well as the tibial side. The third side is a safe technique developed at Harvard. We use an IT band and loop around over the top. So you're not drilling really in a hole, you're just kind of looping around the back, around the growth plate, try not to irritate the growth plate as you go through it, and then go back into the joint, and then go underneath the meniscus ligament and attach it to the proximal tibia with sutures. So that's been shown to work well. It's not anatomic, and then retail rate. No one has kind of directly compared that to the all epiphyseal, but for most patients, then can go out to play and sport, and then if the retail is, you can always revise later on when the growth plate closes. The hybrid technique is used on my group 2, which I'll show you in a sec, where patients are either 14 or 16 and a boy and a girl, and then you don't really care about the tibial growth plate because it's already almost closed, so by the time you close it, or by the time it's a complication within the year, then there'll be no difference because the tibia growth plate will be closed. So you protect the femoral growth plate, but then you don't really care and drill through the proximal tibia growth plate. And then you can add a combination of either, and then the best thing, if you can pick up a proximal peel-off ACL injury, then you can do a repair instead of reconstructing, and you don't have to drill any holes. Sinus staging is used in research in terms of determining how old the patient is exactly, not just by chronological age. And then the guidelines are the one I use in terms of a rough estimate of what the dad and the mom's height is compared to the patient. And then also the time of menses. So usually a year after the first menses, the growth plates will close in girls. And then these are separate in terms of age, in terms of chronological age, unless there's some deviations from the history. And this is what I use in terms of age as well as my recommended surgery. So less than 12 for girls and boys, that's all epiphyseal, protect both sides, femur and tibia. If you're in group 2 in the middle, and then you're a girl between 12, 14, and boys 14, 16, and then boys tend to close growth plates a bit later, so you have to protect and be more careful in terms of the growth plate. Then use a hybrid femoral protecting and tibia drilling through. And then group 3 is almost an adult type ACL, but put a soft tissue graft instead of putting a bone, patella bone, or any form of bone blocks through the growth plate. You have to remember every ACL is different, so we see them in your clinic, in sports medicine clinic, trying to find exactly what was done, whether there's any associated procedures, the rehab will change in terms of the reconstruction, as well as the rehab is tailored to the reconstruction and to the graft and to the meniscus repair and cartilage damage that was repaired at the same time. And then pediatric ACL is very different. Associated cartilage damage or meniscus repair will change the physiotherapy protocol. If there's a big cartilage damage and the patient's almost done growing, then you can expect some osteotomy to offload the cartilage damage or the meniscus injury. So ACL graft choice in the pediatric population has to do with soft tissue graft, so hamstrings or quad. Allograft we don't use because they've been shown to re-tear in patients less than 25, and try not to put a BTB or bone graft across the growth plate. These are general guidelines. So these are incisions for the hamstring and quadricep harvest, soft tissue graft for the pediatric ACL, always confirm intraoperatively for the ACL injury, and then associated injuries. And most patients have fairly small incisions depending on what we do in addition to the ACL. So this is my preferred technique for ACL reconstruction. You can see that both the tunnels on the femur and tibia stay within the epiphysis. Try not to cross the growth plate if you can, if you have adequate bone. A 12-year-old, those lines might change and the bone stock available for drilling might be less, and that's the technically challenging part of the procedure. So as you can see, this patient is still growing, but not as much as a younger patient at 10, 11, 10. And you start to avoid the growth plate on the femurs or the tibia to allow for growth in the femur and the tibia. So these are x-rays of intraoperatively on the left, and then intraoperatively, arthroscopically, just diagnosing the footprint and the location of the tunnel as you drill in, and try not to damage the growth plate as you do so. So as you can see, the pin is just above the notch, and then the condyle is at 5 o'clock. And you don't have a lot of room to play with, so this is a 7 graft for the 12-year-old patient. And you can't put a big graft like a 10 or 11 or 12 because you don't have enough geography to work with. And then you suspend the tunnel, the graft with a button. You're trying to find the best spot possible based on arthroscopy as well as fluoroscopy, and you show your sutures in a very horizontal fashion, and therefore the rehab changes to protect the condyles because you don't want the tunnels to break through the joint, and that's a disaster to deal with. So the rehab changes because of that concept of horizontal tunnel drilling versus diagonal or more vertical drilling. Same thing applies on the tibia, and then x-rays help kind of navigate through the physis, and at all costs you want to drill just once. You don't want to miss, you don't want to re-drill, you don't want to over-drill or under-drill. You just want to find it, line the putt, so to speak, and just put it in. And so this is the challenging part of the pediatric ACL. It's a bit more time consuming, it's very technically challenging. You're wearing lead, you have to use x-rays, and you have to find the sweet spot both on the femur and the tibial side. So as you can see here, there's not a lot of room for the tibial tunnel. The growth plate on the tibial side is a proximal growth plate plus the tibial tuberosity growth plate that loops over to the front. So you have to go a bit more medial in your tunnel and then stay in the epiphysis. And then once you do that, then you flip your button, retension everything, and then just hope that you didn't either overstimulate the growth plate or damage the growth plate. And then this is a hybrid combination when you see the button on the femur, but not the tibia because it was a plastic tibia screw that was inserted. And that was drilled through the tibia growth plate was the plateau. In this setting where you actually avulse the ACL instead of rupturing it, the same concept still applies. the technically challenging part is to place the button or the final fixation in the epiphysis only. And if you have a group 2 sort of patient, then you get lucky because you can go a bit more vertical in the tibial tunnel and go through the growth plate. And then in this case, you have to guesstimate how much damage was done to the ACL. And then in my case, I fixed the bone, but the most important part of the surgery is to retension the ACL. And there's a risk of over-tensioning, and that's the art of that surgery is you have to kind of guesstimate what's normal for that patient and not over-tension or under-tension. And you park that button hopefully in the epiphysis and then wait for it to heal. This surgery is actually very successful if you move them right away because they tend to get stiff. And it's a lot better for patients to pick this up and don't miss the boat in terms of the 3 to 6 week mark, because repairing ACL is a lot better than reconstructing the ACL. And once you do that, that's the easy part, that's the surgery. Then you have 9 months to a year of rehab. And the pediatric patients, there's multiple studies in the rehab side that shown that patients get better after 6 months. And then my average is 9 months to a year. We always try to quote a bit longer because patients will go back earlier. And then that's the reason for the 10-stage milestone is that they need to kind of regain muscle mass, have no pain or swelling, but learn the neuromuscular control and the balance before they go back. And these are all ACL prevention injury exercises that I incorporate in my post-op rehab. Neuromuscular training, the dynamic knee valgus is very important in terms of avoiding, and then soft tissue balance is important. It's not about being super big, it's about being symmetrical on both sides, both the hamstrings and the quad, and then the calf, and all this will also change depending on which graft you use and which deficits you have after the harvest of the graft. So on the left side, you can see there's not a lot of soft tissue bending, but on the right side, she absorbs more, and therefore, a few studies have shown that the more shock absorption you're able to achieve and the softer your landing, then the likelihood of ACL injury is less. The return to play drills is very tailored to the sport and the position, and you have to be careful about who's around during this stage, because if you have the wrong teammate, the wrong coach, this can go very badly in terms of return. New rehab concepts, in 2025, blood flow restriction therapy is here to stay. It's very much shown that it has benefits in regaining muscle strength safely with minimal complications as long as you follow the guidelines. And then what I learned last year from a physiotherapist is you can add distraction and then cognitive skills as part of the 11th and 12th stage of the rehab, because in a clinic environment, it's very artificial that 100% of the concentration on the test, but in real life, you're distracted by players, balls, and then patterns of play and progression of play. So you have to actually test them before you release them to the real world. I did a study in pediatric ACL because I was interested. There's a lot of variability in terms of the studies, and it's shown that defining what a pediatric ACL is very challenging. So that's why bone age is important in terms of research. But in clinical practice, no one uses bone age because it's very time consuming. And then most studies quote just different age, chronological age, and the procedure and the outcome. And then the pediatric ACL surgery is still very much hot topic of debate as of this year around the world in terms of what's the best reconstruction for that given patient. And then what's the complication? Is it re-tearing or growth abnormality or complications from angular deformity, leg length inequality? It's not very documented, and the complications are, I can guarantee, are underreported in the world. The study I did on all comers for ACL injuries, over 503 patients, shows that the risks are graft size, which is easily navigated with different procedures in terms of quadricep, the bone patella tendon and the quadriceps. We can change the size accordingly. Female athletes are increased risk of re-tearing, same risk as the first tear between the age of 12 and 16. And then obviously less than 12, the males more at risk, but it was not shown in the study. And then any age less than 25 will increase risk of re-tear because of the sports specialization, as well as the activity level, frequency of play, as well as the level of recklessness when they play. You have to remember PCACL is not the same as adult, so both the procedure is different, decision making is very lengthy, as well as the rehab is very different. And then this is not a static condition. As the patient grows from 12, 13 to 18 to 25, physiological changes as well as anatomical changes will occur, and then you have to recalibrate every time, every year after you graduate to prevent a re-tear. Thank you. And then this year, January 31st is my symposium, so if you're interested in discussing this more, you're welcome to attend. Thank you. Questions?
Thanks for a great talk. I had a quick question about the pediatric ACL and those that don't present for surgery because they are doing quite well clinically. They have a diagnosed and image confirmed potentially complete tear of their ACL, but they've gone through their rehab, they're doing all of what they need to be doing, they're not having any clinical instability. How long would you wait, if at all, to send them off to the surgeon? Is that something that we can do? Because I know it's happening in the adult population more and more.
Yes. Does the patient have a meniscal tear already?
No.
Yeah, so that's a long discussion because the last piece of decision making in any ACL discussion is, does the patient have instability? So you have to ask, have they tried going back to play already, or do they want to play anything, or they just want to grow and just do homework? And then it depends on the age. The younger the age, the more you have to kind of press and ask more questions. Because if you let that 12-year-old just be a 12-year-old, they will have a meniscal tear in 2 years. So you have to actually warn them and tell them and let them decide. And then nowadays in 2025, you go around the world, the conservative route for ACL tear is surgery, because dealing with ACL re-tear or ACL injury is easier than dealing with no meniscus at 14, 16, 18. It's a disaster at 30. Yeah, get bone-on-bone arthritis, and what are you going to do? So as long as the parents know that, the patient will always want to go back to whatever the quickest, so they'll try to stay away from surgery. And then most patients at that age don't go back to play because the parents don't let them, but the adults will. So the adults are always let them declare themselves. Most of them, because I'm a sound specialist, I already tried to play. That's why they came to see me. But sometimes I catch them very early on and they still don't know what ACL is. So I have to explain it to them. Yes.
Thanks a lot, appreciate it. I'll do a little plug here. I am doing a talk on Tuesday about non-operative management of ACL reconstruction. So
perfect, and there you go.
I wonder, in your regard to the meniscus damage coming on within 2 years, randomized trials of non-operative management for ACLs in the adult population do not suggest, meaningful risk for a meniscus injury in 5 years. What do you think is different in the pediatric population compared to the adults?
They're more active, sports specialization. Most adults have to go to work, but adults are different from kids. Kids play all day in class and gym, and then they will re-tear, if not the ACL, but for sure the meniscus. Because unfortunately, I see them after. I see them 2-3 years after they try non-op and come in now with a meniscal tear. And the discussion about surgery for ACL is always a hot debate because every year there's studies going out that you don't need ACL surgery, right? There's parts of the world you don't operate ever on ACL injuries. And there's rehab techniques with special brace where you hold a hypoflexion at 90 degrees and you can heal meniscus. But the bottom line is if you examine the patient, I can guarantee you the ACL is still torn and the knee is still unstable. And then yes, they show no meniscal tear, but you have to look specifically maybe a subgroup analysis and what are those patients doing? Are they doing still playing football, soccer, basketball? Or they just went back to work and you call them, did outcome scores, say, yeah, I'm okay for daily activities. So if you put that knee to the test, it's like driving a car without the steering wheel. If you drive on on the middle lane really fast, nothing's gonna happen until you wanna change directions. So that's why I recommend surgery to the pediatric patient, and I spend a lot more time trying to discuss the pros and cons and the reasons why I'm recommending surgery in the pediatric ACL as opposed to the adult ACL. And then let them decide. As long as they know the information, then the parents will make the information or the decision for the pediatric patient.
Thank you very much, Rob.